Hi, this is John Watson again, introducing YouTube number 8. We've covered a lot of ground as shown on the right-hand side of this slide. We've talked about care team, leveraging changes for access, efficiency, reliability strategy, behavioral change. Talked a lot about different tools for segmentation and self-management, such as care vital signs, and of course why it's so important to have the patient at the center. In this session, we're going to push on the last aspects of the so-called driver diagram shown on the left. We'll be talking a bit about coordination and related activities such as defragmentation. And indirectly, we'll be touching on your role as a leader. So let's begin. Let's begin by telling the story of Quad Med, which is an excellent example of an organization with excellent leadership and a capacity to reorganize, coordinate care, and cut out waste and, in particular, fragmentation. The story of QuadMed is that it's a wholly owned subsidiary that provides health care to about 9,000 employees and their dependents for a large printing company. As we all know, as shown in the lower left-hand side of the slide, there are all types of overlapping issues and competing interests in healthcare that cause real fragmentation. What QuadMed did was look at that mess and coordinate it, as shown in the diagram, at the center being the patient and primary care. Once centered on the patient and primary care, the organization has tied to that center many other important components and worked very hard to make sure they're coordinated. They use How's Your Health in addition to monitor care and provide feedback to the patients. And from that, we'll have data to look at. The way we'll look at the data is to focus on how they've defragmented care, how they've minimized unnecessary consultations, how they've clarified the consultative role. As shown here in the red, the patient, the primary care provider have a close relationship, direct contracting with high-quality, cost-effective specialists when needed. And that's been the key for QuadMed reducing costs 20% relative to other organizations of similar size. So now let's look at QuadMed performance in its use of specialists compared to us. On the left panel, you'll see little burden of illness, some burden of illness in patients, and you'll see typical practices versus Quad based on illness, and on the vertical axis, the use of specialists. You can see that Quad definitely uses fewer specialists, regardless of burden of illness, than most other practices do. Now, the right panel pushes this a little further and points out that Quad is like many of us. It's also influenced by the geography in which we find ourselves, as illustrated by the Dartmouth Atlas above. You'll recall that in the red areas in particular, there is a lot more expensive care utilized than in the non-red areas. And some of Quad's patients, as well as many of our patients, find themselves in geography, in regions where there is high intensity of care. The right panel now looks at Quad performance of its patients on specialist use compared to ours in areas that are high intensity versus low intensity. And the message is that Quad again does well, but it also is influenced by the geography in which it finds itself. This is an important message as we think about why we do certain things for certain patients. Is it our knowledge? Is it our bias? Or is it the geography in which we find ourselves that has a great influence as well? The cartoon here says it It's a thorn-like in appearance, but I need to order a battery of tests as a reminder to the great degree of variation we have in referrals, consultation, testing, decision-making, treatment. This variation from a patient point of view is quite frustrating. We all have taken the little quiz on how we take care of patients and seen variation. And the remainder of this session will be talking a bit about why we vary and how we possibly can make the variation less and make our care more reliable. One method, again and again demonstrated by Care South Carolina, is to play it simple and explicit. For example, they have their own Care Vital Sign form and a very clear plan for all staff to build on that form and segment patients in categories and do very explicit things for them depending on the category in which the patients find themselves. This is called resource planning and is one way to reduce unwanted variation. Another partial solution is to engage the patient or their caregiver in defragmentation and referral management. We found in careful study that, of course, our revisit interval is really most of the time dependent on our own whims and interests, and that many patients of ours are followed. And when you ask the patients, are you getting any value of follow-up by another physician, a specialist, for example, they will say no. So part of defragmentation is to explicitly eliminate crazy follow-ups that are adding no value, and also at the outset, as shown here, decide what value the referral or consultation might have. And there's a big difference between referring, which means take care of my patient forever, and consulting, which means I want one-time opinion, but it often gets mixed. And many patients, particularly those who are the sickest, require careful care planning, a professional input, patient input or caregiver input, careful monitoring over time, and of course, a care plan that can be taken literally place to place and guide care again and again. The concept of planning care is great, but how do we do it in limited time? And this is where, at least with the IIMH, we hope you'll experiment with the technologies we've provided to you. For example, the personal health record takes advantage of the patient, family, caregiver ability to enter information, prioritize what should be done, and help plan for next steps. And for the very sick, we have, for example, a form that helps people figure out what they want to do and how they need to communicate about very, very complex issues that would take us in the office many, many minutes, if not hours of time. The old way of doing things, where everything comes to the doctor, we all recognize doesn't work anymore. The challenge, of course, is to figure out how to redesign practice so that it will work much better for all involved in the practice and the patients and families who visit it. The materials we've given to this point now provide you with more than enough to think about. And at this time, it's very important for you to now start thinking about what are going to be your next steps. What of all the ideas you've heard do you want to work on now and think about working on over the next 3 months? Because the IIMH, again, gets you started on a journey. It's not the end or destination. And you can continue to follow on the listserv and get opinions as you move forward and make your practice that much better.